From the JAMA Network, this is JAMA Pediatrics Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Pediatrics.
Hello again, podcast listeners. This is Dimitri Christakis, Editor-in-Chief of JAMA Pediatrics. With me, as always, my colleague, dear friend and Associate Editor, Dr. Alison Galbraith from Boston Medical Center. Hi, Allie. How are you?
Hi, I'm good. How are you?
I'm great. And this is going to be, I think, our fourth or fifth podcast in the new format.
Yes, new and exciting.
That hopefully everyone has come to appreciate. And in this format, we bring on an expert to discuss with us an important pediatric topic using an article we've recently published as a springboard. And today's expert is Dr. Melissa Gilkey, who is a social and behavioral scientist on faculty at the University of North Carolina Gillings School of Global Public Health. And she is one of the leading HPV vaccine researchers in the United States. And we've brought her on to talk about HPV vaccination. Hi, Melissa. Good to have you here.
Hi. Thank you for having me. I'm really pleased to join.
Great. So, Allie, what made us think of bringing Melissa on this month?
Yeah, so we have two papers that actually touch on HPV vaccination from a little bit different perspectives. So the first one is called Multilevel Implementation Strategies for Adolescent Human Papillomavirus Vaccine Uptake. It's by Vinnie Rutten and colleagues from Mayo Clinic and Yale. And so we'll talk about this, but HPV vaccine uptake is suboptimal. And so in this study, they used a cluster randomized controlled trial with a step wedge factorial design to test the effect of two evidence-based interventions on vaccination rates among more than 9,000 11 to 12-year-old children in 6 primary care practices that are part of the Mayo Clinic. So they did the intervention in steps. So they had no intervention and then one of them and then both. And so basically the two interventions were, one was a reminder recall to the parents after the child's 11th birthday. And then the other was an audit and feedback for providers about their own personal success with vaccine uptake. I think it was through the mail to them. So what they found is for usual care, there was only 22% of the kids who got a dose of HPV. The reminder recall, there were 35% who got a dose, and the provider feedback alone was 30%, and both together were 40%. So the odds of HPV vaccination were significantly higher for reminder recall and also for the combination, but not any different for just the provider feedback alone.
And not very good overall, anyway.
No, right. These were just 11 and 12. They didn't follow them out further. But right, so definitely we'll talk about that with Melissa because she's done a lot in that space. The other one is just to kind of document trends in HPV vaccination. So this was from Jody White and colleagues about trends in vaccination. They used the U.S. National Immunization Survey teen to look at both initiation and completion of HPV vaccine series before age 13. And so they just documented the rates, which are also not ideal, although they have been improving. Basically, the initiation rates and the completion rates have gone up between 2018 and 2021 in both males and females, but they're still, the majority of 13-year-olds did not complete the series.
Melissa, let's start with the elephant in the room. The question you probably get asked all the time, why are the rates so low?
I guess I would start with kind of a qualifier that they are low. They have been getting steadily better over time. So when we look at older kids, 13 to 17-year-olds, about 3/4 start the HPV vaccine series, which is much better than it was 10 years ago. Less than 2/3, I think it's 63%, actually complete the series. So we have been steadily getting better over time. And I think that's due to a really huge investment by CDC and AAP and others. But we still really do, as we saw in the White study, have an issue with guideline consistent HPV vaccination or completion on time. So I just want to note that it's not a totally bleak picture. Things have been steadily getting better.
You're glass half full kind of person, it sounds
I'm glass half full. Yeah, I mean, this is an issue that as a country, we've really been working on. There has just been really strong support, especially from CDC for a long time. And so I think that's important. It has been working more slowly than we would like, but it has been working. But in terms of what makes HPV vaccination harder than Tdap or meningococcal vaccination, which are also delivered to that same age group, but much higher in terms of coverage, I think of a couple different things. One is suboptimal or weak communication by physicians and nurses when it comes to recommending HPV vaccination. Parents do turn HPV vaccination down more often than other vaccines. they tend to go on to get it later if they have another opportunity, but that creates a kind of snag in the system. I would say we have a not very supportive policy environment since not many states require HPV vaccination to get into middle school. And then there's some more structural issues around inaccessibility of vaccination data and that kind of thing.
What role do you think vaccine hesitancy, and especially now in the post-pandemic environment, anti-vax sentiment, how much does that play into HPV, do you think?
I would say that it is definitely a factor, but not always in the way that people imagine. I think when people think about vaccine hesitancy, they tend to think about what some people call anti-vaxxers, people who are really dead set against vaccination, who have really deep-rooted concerns about it, and just are really going to be hard to convince. There is certainly some of that with any vaccine, but what's much, much more common is that parents may just be a little ambivalent about it. They're not sure that their kids really need it. They're just not sure about it. And then that's really compounded if the physician or nurse doesn't seem sure about it either, right? If they're not recommending it with the confidence that they recommend with other vaccines. But I think what's really interesting about HPV vaccination is that if you look at parents who initially decline it, the majority of them go on to get it for their child or plan to do so. So we did a survey, this has been a number of years ago, with parents who said the first time they were offered HPV vaccination, they declined it. And over 2/3 of them either had gotten the vaccine by the time that we surveyed them, or they plan to get to it in the next year. And so I think that's different from how we sometimes conceptualize vaccine hesitancy is this really, again, like this really deeply felt fear or concern. It's more about ambivalence, and sometimes parents just need more time.
I think of it as maybe potentially cognitive dissonance. I mean, I think the idea that HPV vaccination has associated with it, the transmission route, which is, sexual, is something that puts front and center in the parent of an 11-year-old, something that they just don't even want to think about. It's funny because the hepatitis B vaccine, which we give to infants, is also transmitted through sex. And when you have that conversation with a parent of an infant, as I do in the nursery, it's so far away, right, that we even make a joke of it. We say, well, they're not going to be at risk for this for a long time unless they get a transfusion between now and then. But it's just best to do it. And I mean, is that the distinguishing thing here?
It's kind of like, okay, and now we do the Hep B vaccination. I think, Melissa, you did work on this, right? If you announce something versus if you have a conversation. And so I think people think they should have a conversation about HPV, and maybe people are more ambivalent, whereas if you're just like, this is what we're going to do, this is what we always do.
Or if
like
you just say it's a cancer vaccine and don't tell them how it protects against cancer.
Yeah, I would say it's both things. Pediatricians definitely say that 11 to 12-year-old age is tricky, right? Because there's just such a diversity in how their patients are presenting, that some of them seem much more mature and that others are kind of still coming in with their American Girl doll or that kind of thing. That's what I've heard one pediatrician say. So it's not a uniform population at all. But I do think that some of it is also physicians and nurses being overly concerned that the parent will have a bad reaction or that they'll be implying something about their child needing the vaccine. And so in our early work, we did find that pediatricians did tend to talk about HPV vaccination much differently from other vaccines. So it might sound something like, oh, your child needs Tdap and meningococcal vaccines for school, and then there's HPV vaccine. And it's not that they didn't believe in it. And it's not that they ever said anything bad about it, but it was that kind of damning by faint praise, right? They just talked about it differently in a way that if you were a parent, you could understand thinking, well, what's wrong with that vaccine, right? Why is there that long pause, and why is it offered as an optional thing as opposed to what it is, which is part of routine care?
That presages the next question, which you alluded to before, which is why, and maybe the answer is the same, but why is it not mandated? I mean, it's a communicable disease. It's obviously communicated in a different way. Is that the pushback? Is it that it's a sex vaccine and school districts can't even bring themselves to suggest that it needs to be done?
So it does have to do with, because those school entry requirements are enacted at the jurisdiction level by states, for example, part of it is just what the priorities of that state are. There are some jurisdictions that have enacted school entry requirements. Rhode Island, which has always done really well in terms of vaccination coverage, but now has the highest coverage in the U.S., enacted them a few years back. Also Virginia, Washington, D.C., and then more recently Puerto Rico and Hawaii.
And did they see the rates become comparable to everything else then? I mean, did it really work?
So it's interesting, the early evaluations of school entry requirements didn't look that great. And in part, that people suspected that they had such generous opt-out provisions within the requirement that they just weren't really doing their job. And then you can also imagine 10 years ago, when rates were really low, that would be a lot of work, right, for a school district to actually enforce the requirement. However, more recent studies, especially in Rhode Island, show some promise. So I actually feel really optimistic about school entry requirements, and I hope to do a little bit of research in that area myself.
Although the mandate issue, I think, is hard because of COVID vaccination and mandates about that, too.
Those requirements were one of the few interventions that really work, but there can be a political cost and an implementation cost to making them happen. And so you have to balance those two things, which is going to vary a lot by state.
You talked about implementation costs. This study that we just saw, that was a lot of work to do reminder recall. It's a lot of work to do audit feedback. Where do you think is the most bang for the buck with those kinds of interventions, at a practice level or at a parent level or provider level?
I think definitely at the practice and provider level. And I think we're in this interesting moment in which primary care has consolidated so much, right? Even in the time that I've been working in this field, there aren't really private practices anymore in pediatrics the way there used to be. The health systems are getting kind of bigger and bigger and bigger. And I think there are opportunities there. My hope is that with those bigger systems, that practices will have better QI infrastructure, that they'll have better data, that they can do audit and feedback, for example, and that they have people whose job it is to help them. I think the downside is the other shift that I've seen in the time I've been doing this work is just the kind of fee-for-service model. You know, the culture of these systems differ a lot. In the past couple of years, we've definitely heard a lot of physicians say, I can't participate in a quality improvement project. I can't do your training because I'm worried about my RVUs and my system won't give me the permission that I need to do this work outside of my role in patient care. So there are pluses and minuses, but my hope is that the infrastructure is really going to help. And I think it's such an exciting study, and it just demonstrates what a really high-functioning healthcare system can do if they put their mind to it, right? Like they did 3 years of intervention work. That's really great and unusual and probably what it takes, right?
Well, I'm curious, maybe we can go out on this because a lot of our listeners are frontline pediatricians. You suggested that they are part of the problem, or at least that they can be part of the solution in terms of how they present this. So aside from the practice level and structural changes, what can an individual provider do to sort of overcome the hesitancy to immunize their children in a timely manner with HPV?
Yeah, well, Alison alluded to the idea of, it's sometimes called a presumptive recommendation, which refers to a way of recommending HPV vaccine that really normalizes it, that puts it in the context of other vaccines and other routine care by starting out with just a very directive approach. Your child is now 11 years old. He's due for 3 vaccines. We can give these at the end of the visit. So instead of parsing HPV vaccination out and making it something other, it's really including it in that package of routine care with the expectation that the default will be to get the vaccine. If parents do have questions or concerns, it's obviously really important to slow down, right, and answer those. And we do a lot of training about ways to do that effectively. And then the third really important step is if a parent declines, to not take that as a forever answer, but to really take care to bring it up again at the next visit. Because all of our data suggest that, again, it's just a longitudinal process, right? Some parents just need more time. And if they have a second opportunity, a lot of them will say yes.
Thanks again, Melissa, for your time and sharing your expertise with us and with our audience. I certainly learned a lot, and I hope that the information's been helpful to everyone else.
Great. Thank you so much for having me.
This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.